This is a very interesting topic. I lived here in Prescott for 14 years, and then I moved up to, in Phoenix for 14 years, then moved up to Prescott, which is a rural area. My story is a little interesting, which we're not going to get into, but I used to do outreach programs, and I used to travel I was a solo practitioner, was in a group practice and went solo. And I used to travel to these outreach areas because we used to get all these patients from Lake Havasu, from Kingman, from Flagstaff, Prescott back in the days. They didn't have any EP services there. They didn't have much cardiology there. And there was poor care being provided. So I one day decided, let me just go up there and provide services and do outreach clinics and then bring patients back to Phoenix for procedures. So that's how I started. And lo and behold, after 10, 11 years of doing outreach services, I moved to Prescott because they asked for me to come and join them there. I have no financial disclosures. And as I said, these slides, thank you to Dr. Bond and Kerry that I will be presenting these slides. So if there's any problems with the slides, it's them, not me. So this is a threefold objective for me to present today. Number one is to summarize the existing data on rural population, communities, and health outcomes. Secondly, I want to talk a little bit about how to make it a priority in programming, providing research and other policies to help improve services in the rural communities, and to understand and address the unique health needs of these people that are residing in rural America. Before I move forward, I do want to say a big thank you to our support staff. I'm an electrophysiologist, so everything that I do, I need support staff, not just the staff that are in the lab with me, but the support staff for mapping equipment, for mapping ablation procedures, for devices. And when I moved from Phoenix to Prescott, my biggest concern was, will I have the services? Because living in a metropolitan city, it was easy. You pick up the phone, you call and say, hey, I need a device, I have an add-on procedure. But to rearrange everything in a small community 2 hours away from any help, in the middle of the day you have something, all I can say is thank you. All of you back there who are sitting there, thank you for helping us to be able to provide the care we provide to our patients. So going into the discussion, health and healthcare disparities are commonly viewed through the lens of sex, gender, race, and ethnicity. But actually, they occur across a broad range of dimensions. What determines health? What are these social determinants? It's vast. Economic stability, neighborhood and physical environment, education, food. We know people on food stamps, they don't do very well. They're not healthy. Their healthcare accessibility, how many providers there are, the community and social context, all these things play a big role. And I didn't really understand these things till I really started practicing there in rural community. The biggest thing is zip code and geography. It makes a big difference. And this is this is from Phoenix. 2 60-year-old women living 10 miles apart in Phoenix, Arizona, have been prescribed hypertension, angiotensin receptor blockers. Both have family history of type 2 diabetes and have missed their last few annual checkups. What should their care plans look like? Should they be different? Do we ever think about these things working in communities, looking at patients that come? I always look at the zip codes. I do not know, but I've always done that. And there's a big difference. Honestly speaking, when they were doing these studies, we found that there's a major difference because one person will not have the transportation, even though they're 10 miles apart. They will not have the grocery stores. They will not have the funds. They will not have, it's poverty line, maybe just 10 miles away. And that will affect how they do, how the medical future is going to be. So this translates into the fact that despite several decades of, I'm sorry, I think I went through a slide. No, I didn't. Sorry. So, we need to look at these things because this is very important. And what is rural? How do you define rural? I really didn't know what rural was till I read these slides, so thank you. So areas with low or geographically diffuse populations with urban core of more than 10,000 but less than 50,000 population, or with no urban core. So where I live in Prescott, I looked all these things up for this talk. because I don't pay attention to these things. And our population is 47,000, but there are small little areas right across Prescott Valley, Chino Valley. They come out to about 150,000 population or more. And then we have Kingman, Lake Havasu, Flagstaff. All these areas are underserved. Believe it or not, we don't have that much physician care to provide these patients services. What does that result in? So people who are living in rural areas, the overall mortality and cardiovascular mortality is on the rise because of lack of services provided to them. And it is surprising to say that under this definition, rural populations in the US are heterogeneous and comprise 60 million people. This is the map of the US, as all know, and this translates into 20% of the US population, which makes up to nearly 3/4 of the land. That is amazing. You know, we think that with our medical profession, with advances in medicine, things are better, but when you look at urban versus rural, the blue is the urban and the orange is the rural. So you can see that there's disparity in the patient care that is provided and the mortality and morbidity. In the mid-1980s, rural and urban deaths per 100,000 population were approximately equal, but by 2004, there was a gap of 77 excess deaths per 100,000 in rural areas. And by 2016, this has nearly doubled to 134.7 excess deaths per 100,000, which is almost a 20% disparity in our death rate. This is a little busy slide, but what it talks about is the rural overall demographics. What do people, you know, I live in Prescott. What is Prescott? Retirement area. A lot of AFib. I'll always be in business. I'll never have to worry about that. But that's because people are coming to these areas. They're coming from California. They're coming from other places. They want to come and retire in a smaller community. They don't want to be running around in traffic, in pollution. So what do we have in our community? Elderly people. An estimated 19% of population that are here are more than 65 years of age in rural locations. And this is compared to 15.6% of the nation's population as a whole. What else is in rural areas? Poverty. We don't see that right now, but when you are living there, you see the small little areas. They call them people living in the boonies, off the grid. And that is because of poverty. There is no transportation, there is nothing for these patients. And of course, diversity. Even though 83.5% of the non-metropolitan residents are non-Hispanic white, Hispanics and Asians are the latest growing rural subgroups. And depending upon what part of the country there is, in the South, there are Black, we all know the different racial distribution. So how does cardiovascular disease fare in rural America? We all know the answer. We've heard all these beautiful speeches today. Yes, it is worse. Data from 2017 CDC National Health Interview Survey showed a 40% higher prevalence of cardiovascular death amongst rural residents compared to their counterparts in small metropolitan or urban areas. Rural areas have higher death rates for cardiovascular disease, including stroke, than urban areas, and the gaps are widening. The steepest risk of death and mortality from stroke is in the rural South, unfortunately. We are in the Women's Conference, so what about women in rural communities who make up 22.8% of the US women population aged 18 years and older? Is it good or bad? It's worse. Reading these slides, it just made me feel sick to my stomach, and listening to the talks from this morning already, it's saddening to see what we are dealing with. What do women, they are reporting self-reported fear of poor health status, unintentional injury, motor vehicle deaths, cerebrovascular disease deaths, suicide, cigarette smoking, obesity, just difficulty with basic actions or limitation of complex activities, and incidence of cervical cancer. Our cardiovascular ischemic heart disease comparison is, of course, higher in the rural as compared to the urban area, and higher rate of maternal mortality. We have a very robust OB unit, so One part is Prescott, the other one is Prescott Valley. So higher elevation, little lower elevation, so that's the valley. And that's where the OB department resides. And it is amazing how many deaths or how much bad outcomes they have. Young population, and it's not that rural. But still, this is the difference between what I'm hearing today is making sense. Rural maternal mortalities are much, much higher. Pay attention to the top slides. Look at that. So we are talking about women. Look at the women who are younger. This is alarming upswing in the cardiovascular deaths among rural women 55 years or younger since 2009, according to a review of national data on coronary artery disease deaths between 1999 and 2017. Amazing. Look at the first two, women 35 to 44 and 45 to 54. This is 2021. This is 2017. Is that believable? Unbelievable. When I looked at that, I had to look at it twice and say, this can't be true, but again, this is the reality. And what is the biggest determinants or indicators for women's health? Body mass index, health status, smoking, health history. All these are worse for rural versus urban women. So the increase in obesity, smoking prevalence, and greater physical inactivity has affected women greater than men. So I chose to start hiking, living in the rural community, and I refuse to be one of them. Studies also suggested that middle-aged women with diabetes and metabolic syndrome have a 5-fold increase in the risk of coronary artery disease or acute MI compared with non-diabetic women and men. When women are diagnosed with hypertension, hypercholesterolemia, or diabetes, they are undertreated or not even treated at all in our communities. Depression is major in our communities. Perceived stress, it's worse in young women, and pregnancy bad outcomes is worse in our communities. What else is bad? We don't have women providers in our community. People all want to come and see me. I'm an electrophysiologist. I do not do any general cardiology. I've done electrophysiology for 16 years. I refuse to do general cardiology. It's like, I don't know how to treat hypertension and hypercholesterolemia, but I know how to treat your AFib and your heart failure. But they all want to come and see me as a primary care provider. I probably spend more time with them just talking about, even though I won't do general cardiology or primary care, but they feel comfortable because it's a women physician talking to you, and we don't have that in our community that much. So patients really don't go and get care. There is geographic maldistribution of healthcare providers, as I said, with only 9% of nation's physicians practicing in rural communities, and I feel so privileged that I'm part of one of those 9%. According to the Health Resources and Services Administration designated health professional shortage area statistics, 59% of primary health shortages occur in rural spaces, with approximately 3,890 providers needing to close the gap in care. Who wants to come and join us? Anybody wants to raise their hands up? This is sickening. This gap is even wider for specialty services. I am the only electrophysiologist in Prescott, but I service a major population of over 200,000 patients. And that is busy and unbelievable. Nobody wants to move. Even for me to move up there, people, we have people, we are interviewing cardiologists to come and join our practice. We first of all don't get too many applications, and when we do interview them, they don't want to join us because it's not a metropolitan city. Annually, 3.6 million Americans fail to receive medical care as a result of transportation issues. It's 2021. How can we believe in that? Everybody has a car in the US. I come from northern India. Yes, I can believe over there, but not here. But like I said, yesterday when I was driving up here, this is true, this is real. I was driving up here and I was a little late for the dinner last night because I had a patient in the ER with non-capture, pacer-dependent patient with a bi-VAICD with non-capture, intermittent. He lives off the grid. Luckily, we had remote monitoring. I read it before I was coming here. I had to call the patient to come to the ER, waited for him to show up. He lives off the grid. I don't know, there was nothing wrong with the device, but there was true loss of capture. Why did I have to wait that long? Because the guy did not have transportation. He lived somewhere in a place called Ashfork, and he had to wait for his son to come and pick him up. It took him 4 hours to get to the emergency room. This is the reality of what we live with in our community. So, I think that explains everything on this slide. I don't need to go into this. So this leads to the inevitable conclusion that intensification of public health efforts aimed at increasing the awareness of cardiovascular health of rural women during young adulthood, adolescence, and childhood are necessary. Dr. Bond, do you want to add something to this slide? Because premature coronary disease is a result of exposure to cardiovascular risk factors during adolescence and early adulthood, a focus on primordial prevention is necessary with solutions to seamlessly allow for this. So there are two places that we need to work on. One is the provider level, that is our side, and then communities and healthcare policy level. We need to be educating everybody in the community. We need to do, telemedicine has really helped, not much for me, but for other services, because patients are able to get there. We need to provide CMEs, programs for more education, which we don't get over there. We need to increase the number of PCPs, number of specialists, so that we can provide the care for this growing population in our community. In summary, the population of rural America will continue to grow, age, and become increasingly diverse. As it stands, it is clear that premenopausal women, especially women of color, living in rural communities are at the greatest risk for the worst cardiovascular health-related outcomes. These findings call for an intensification of public health efforts regarding cardiovascular risk factor awareness, assessment, and control, especially for young women in rural communities. Because premature coronary disease is a result of exposure to cardiovascular risk factors during adolescence and early adulthood, one wonders if efforts for primary and secondary prevention are enough, or is it a focus on primordial prevention, which is the most necessary at this time?